All right, hello again, class, and welcome to another group presentation. This is group number 2. So while you are likely watching this as the second presentation, group number 2 has not had a chance to see how this is done before. So in certain ways, they are guinea pigs for this class or for this presentation as well. They're going to be talking about osteopathic medicine, which is, to me, a really fun topic to discuss. And so I'm really looking forward to what they have to say. I'll go ahead and turn the time on over to you, ladies.
Thank you. Next slide.
So osteopathic medicine is based on the theory that disturbances in the musculoskeletal system affect other bodily parts, causing many disorders that can be corrected by various manipulative techniques in conjunction with conventional medical, surgical, pharmacological, and other therapeutic techniques. Next slide.
So the question was posed, why is there a second medical degree? Brian Kratchman, who is a DO, said a DO is an osteopathic physician, while an MD is a medical doctor, an allopathic physician. Just to kind of help clarify what allopathic means, it's a term that's the practice of traditional or conventional Western medicine. So that's viewed differently than osteopathic medicine, which is more homeopathic based, and they deal more individually with the patient. So a DO is accredited by the American Osteopathic Association, and that's within the COCA, the Osteopathic College Accreditation. They like I stated, the DOs focus on the body as an integrated whole. They don't solely treat the symptoms. They try to treat the person and all the processes of the body that could be contributing to the issue. Their programs have a more holistic emphasis versus the allopathic emphasis. The DOs are required to have 300 to 500 more. They have additional hours of study that focus specifically on the skeletal system and the interaction of the human body with the diseases. It's also felt that DO programs typically place an emphasis on primary care. They say that most DOs are PCPs, which is primary care physicians, or internists, that type of base. They often address the issues with the patient from both a medical and lifestyle perspective, and they try to work hand in hand with the patient in a partnership to improve health and wellness. It's also, in my studying, shown that DO schools generally have less stringent admission requirements. They allow for a lower GPA, like a 3.4, and a lower MCAT score right around in the 30 range, whereas you have to have higher than that to get into an MD school admission. Next slide.
So who started all this? Andrew Taylor Still. He was born in 1828 and he died in 1917. He was an American-born physician, surgeon, and author who practiced during the Civil War. And during his time, Dr. Still felt that most medical doctors often caused more harm than good when treating their patients. He believed that the body was innately capable of healing itself. He later went on to found the first osteopathic School of Medicine in Kirksville, Missouri in 1892. And he named it the American School of Osteopathy. He taught physicians to look at the whole person, not just the individual systems. Next slide, please. And there we go. Is there competition between MDs and DOs? Well, there used to be. In the generation of most of our parents, there was competition between the two. For instance, if a DO moved her practice to a town where there were only MDs practicing, the MDs were sometimes very skeptical. Sometimes they would tell their patients that they were not real doctors or not as competent as MDs. In fact, in California in the 1960s, the American Medical Association spent a pretty penny to end osteopathy and issued DOs MD licenses in 1962. They continued to do this until in 1974, when many prominent DOs protested this move and had it overturned. There used to be two different residency paths for physicians, which further segregated the two types. In 2014, the Association of American Medical Colleges merged into one accrediting system. Now, most patients do not even know if their primary care physician is a DO or an MD, and they may not even care. Next slide, please.
So both MDs and DOs are required to obtain a bachelor's degree and take the MCAT prior to admission into their graduate school program. Most complete 4 years of basic medical education in addition to training in their specialty. Afterwards, they must pass state licensing exam, and both physicians are capable of practicing in all 50 states. Both MDs and DOs use an evidence-based methods of treatment and can practice in any specialty and prescribe medication. MDs only, however, MD stands for Doctor of Medicine, as we addressed previously. And they attended and graduated from a conventional or an allopathic medical school. Currently, MDs account for approximately 93% of actively licensed physicians in the United States. They focus mainly on diagnosing and treating the symptoms and illness, and approximately only 35% choose to practice in primary care, with the remaining 65% choosing specialized medicine. DOs as Doctor of Osteopathic Medicine, and they attend School of Osteopathic Medicine. Currently, they account for 7% of the actively licensed physicians in the U.S. As previously stated, they treat patients, not the disease, and emphasize the mind, body, and spirit as a whole. Approximately 60% of DOs choose to practice in primary medicine or primary care. So what's the difference? DOs receive additional training in the musculoskeletal system and incorporate osteopathic manipulative medicine into the treatment of patients' illnesses and diseases. Next slide, please. Next slide. Thank you. So what is osteopathic manipulative medicine? So all DOs learn this hands-on technique in medical school. Many use it in the practice along with, or in some cases instead of, other treatments such as medication and surgery. This practice includes 40 different techniques. The main ones focus on soft tissue, stretching and pressure, applying pressure directly to the muscles, or focusing on muscle energy, which is a belief system that if muscles are moved in a specific direction and then they apply counter pressure, that healing can take place at that point of pressure. Also, cranial manipulative medicine is when soft pressure is applied to the skull to promote healing. And then myofascial release is when firm but gentle pressure is applied to release tension in the fascia, which is the soft connective tissue within our body and the linings of our organs. So DOs receive specialized training to be able to do all of this. And before they use this method, they first consider the person that's within the patient, recognizing the interrelated unity among all of the systems within the body, each working with the other to promote overall health and wellness. They believe that tightness and restriction in nerves and muscles can be caused by or lead to additional physical ailments. So they believe in treating that tightness and that restriction in order to alleviate other symptomatic problems. And they do this by using their hands to diagnose, treat, and prevent illnesses or injury. As a treatment, osteopathic manipulation attempts to improve joint range of motion and balance tissue and muscle mechanics in order to relieve pain. Doctors of osteopathic medicine are hands-on. They are taught to touch their patients and interact with their patients so that it's a more personalized approach to care. Next slide. Okay, these are the tenets of osteopathic medicine. This is the foundation that the American Osteopathic Association House of Delegates approved as being the foundation of their approach to medicine. The first is that the body is a unit. The person is a unit of body, mind, and spirit. The second, the body is capable of self-regulation, self-healing, and health maintenance. And then the third is structure and function are reciprocally interrelated. And then the fourth being rational treatment is based upon understanding of these basic principles. So that fourth tenet just encompasses the three and states that their course of treatment is based on those principles. Next slide. Okay, this is just a brief overview or an example of what an osteopathic curriculum looks like when you do graduate school. This breaks it down into which courses you take when and in conjunction with what and how many clinical rotations are required, and then the areas of specialty in which those take place during your third and your fourth year prior to beginning your residency training. Okay, and then next slide.
So this shows the locations of all the osteopathic medical schools. The school locations have grown dramatically over the years, and they have many more options than they used to. If you go to the next slide, Brother Gage, slide 11, it gives a breakdown of all the schools. There are currently, they accredit 33 colleges, and they offer instruction at 48 different locations in 31 different states. So this osteopathic medicine has grown. Next slide, please.
So I happen to work for a physician who is a DO, and I've worked with him for the past 2 years, and so it made it very convenient to be able to interview him. His name is Dr. Benjamin S. Crouch, and he graduated from Des Moines University College of Osteopathic Medicine in 2008, and he finished his residency at Michigan State University in 2012. He decided to move to Utah to be closer to family, and currently practices with Revere Health Orthopedics in Utah County. He is from a family of physicians. He has 4 brothers who are all doctors, a brother who is in medical school, and another brother who is a medical officer in the Navy. His father is a well-respected obstetrician. So going to medical school was a choice he didn't even have to think about. It was just ingrained in him throughout his growing up years. The question came down to whether he would go to an MD program or a DO program. Next slide, please. All of his family happened to be MDs, so he's very familiar with their struggles surrounding getting into school and the pressure that came with that. Before medical school, he shadowed a DO who was very kind and personable, someone who broke the typical mold of an MD. I think a lot of MDs have sort of a stigma of having kind of a God complex, meaning they're arrogant and kind of want nothing to do with anyone else, especially the lowly students who shadow them. And I've kind of seen a lot of that working with lots of different physicians. This particular physician that he was shadowing told him that DO school was more family friendly and a little more laid back. So DO school was a natural fit for Dr. Crouch, as family and friends are very important to him. He also liked the aspect that osteopathy surrounds being able to use the body to heal itself, and that not all pain has to be treated with medication, injections, or surgery. Next slide, please. So, like I said, I met Dr. Crouch in 2015. I was having some pain in my scapula, in my shoulder blade, and I went and saw him, and he told me it was called a posterior rib, meaning that the rib kind of sticks out and that the scapula moves over that rib that's sticking out, and it causes pain, and that he would be able to put that in place. Most medical doctors, they do not know how to manipulate the body to relieve pain. So DOs are are unique in this regard, and they are somewhat similar to chiropractors. He did this technique that put my rib back in, and voila, my pain was instantly gone. When a patient, for example, has a headache, most physicians would grab their prescription pad and write out a prescription for medication, or maybe have them see somebody else, but not DOs. A DO can do a technique that releases the occipital muscles, the muscles that are behind the base of the skull. They can gently put pressure on those occipital muscles in the neck to relieve tension and pain. And I've seen that happen many, many times. And it's pretty amazing how it relieves headaches and neck pain. I feel that the body can do a lot of things, and our bodies are amazing. And what doctors of osteopathic medicine can do to help their patients is amazing. So I'm pretty impressed. How about you guys? Next slide, please.
Sorry. So who is Abraham Flexner, and what is his role in all of this? So Abraham Flexner was the sixth child born to Jewish immigrants, and he was the first to complete high school and attend college in his family. He decided to become an American educator, and he founded a college preparatory academy in his hometown of Louisville, Kentucky. He implemented a learning style where students learned by doing, and they learned to solve problems rather than rote memorization. He became a member of the elite circle known as the Hopkins Circle, which was an elite group of highly educated philosophical thinkers for their time. In 1908, he published The American College, in which he addressed the college experience in America, and it gained the attention of the Carnegie family. And the Carnegie family at that time, their philanthropic focus was on improving the healthcare system in the United States. So they charged Abraham Flexner with investigating medical schools in the United States. He did this by visiting each one, traveling around the country, which at the time there was not airplanes or simple fast means of transportation. And so he had to make sure that his time at each school was focused and precise. And after he published the Flexner report with his findings, he went on to establish the Institute for Advanced Studies at Princeton. Much of the credit for the way medicine is practiced today can be attributed to Abraham Flexner and his critique of medical education contained in the Flexner report. Next slide, please. These changes became evident after he was hired by the Carnegie Foundation to investigate the medical schools in the United States and Canada, then provide suggestions for their improvement. Flexner was not a physician, so this at the time didn't seem like the best choice by members of outside circles. And he did not have any medical school experience before going into the investigation. However, the Carnegie Foundation perceived the cause of the problem to be rooted in facilitating the education of the physicians, and felt that an educator would be better equipped to address the dynamics of the problem. Flexner's inquiry at each school focused on access to hospitals, the hospitals that were nearby or the hospitals that were considered an entity of the medical schools. He also focused on admission standards, the physical facilities themselves, whether or not they had lab equipment or access to cadavers, and instruction by physician scientists rather than educators or laymen that did not have a medical background. He discovered that medical schools had vast differences in entrance requirements. Some required a college degree, while others didn't even require a high school diploma. In addition, some medical schools were graduating physicians that had little to no patient interaction. Some of the medical schools were in rural areas where the nearest hospital was not within an easy distance. So some of these physicians that were finishing school had no patient interaction at the time that they graduated or finished the program. So once the results were tabulated, schools were assigned to one of 3 categories based on their performance. The first group was considered successful, meaning little to no improvement. They rated among the elite medical schools at the time, such as Johns Hopkins. The second group could see improvement with financial assistance. And then the third group warranted closure, that there was no hope for them to improve or attain the standards in which Flexner felt was necessary. So the Flexner report became the academic model for medical education in the United States, creating a strong foundation in biomedical sciences, where those were addressed the first 2 years, and then coupled with hands-on training. And that's where we have the clinical rotations that we see doctors and physicians completing now with their medical school education. Next slide. And there's our resources.
All right, all finished?
Yep.
Great job. Let's go and do a quick Q&A on a couple things here, and then we'll wrap it up from there. So I guess my first question would be, did any of you have any strong opinions about DOs versus MDs to begin with? And has that changed since you did research on it?
Absolutely.
Go first.
I have always been pro DO. When I am looking for a primary care physician or any doctor, if they have a DO behind their name, that's going to be my go-to person. Just because they are a lot more personable. They really try to get to the root of your problem, and they're not just going to give you a prescription for medication, which I think in a lot of cases that's just not necessary.
And was this your opinion before the research? Is this what you felt before?
Yes. Oh, yes. Yeah.
Anyone else?
Yeah, I think pretty much all 3 of us were strongly opinionated and or carried a preference towards DOs. I actually had planned to go to medical school, to an osteopathic medical school before life happened. So I've always had that inclination towards the holistic approach of becoming a doctor of osteopathic medicine. I have always chosen them as my primary care physicians, as well as the pediatricians for my children as well.
I've had good experiences with both MDs and DOs. I've worked in them at a healthcare facility here in Utah for the last 6 years, and I've been in the medical industry for probably the last 15 to 18 years. I've had good experiences with both, like I've stated. However, I have had an experience in the last 2 years with the DO where he's spent the time with me to go more in depth with some medical situations that the other doctor kind of just glossed over. And we found out some things that he's been able to help me with that I was feeling kind of helpless about. So.
Cool. So given the research you've been through or your feelings about DOs, why do you think someone would choose to go to traditional medical school and become an MD versus a DO? Or on the same side of that, why do you think someone would choose to go to an MD rather than a DO in those circumstances?
I think an MD would be it can be a more specialized field, more surgical interventions if they're looking to do, like neurology, those kinds of more specialized industries, that you would have to attend an allopathic MD school. So I think that would be one of the reasons.
I think there's also consideration that needs to be placed on where you're going to choose to practice. If that decision can be made prior to choosing a medical school versus an osteopathic school, or an allopathic versus an osteopathic. I know that I've lived in several different regions of the country, and I know that there's some that hold a high preference towards MDs over DOs. There's still that
Stigmatism.
the judgment and the prejudice towards DOs and whether or not they are legitimate physicians or not.
Well, and then there's the fact that 93% of physicians go the MD route and only 7 go the DO route. So I find that's kind of interesting because I feel like I know quite a few DOs, and maybe that's just because of the lifestyle that is offered here in Utah County. You know, it's very family-based, family-friendly, so that seems to attract a lot of DOs. And I think a lot of people probably don't understand what a DO is, and so they're not educated in that.
Mm-hmm.
So they're like, oh, well, I know what an MD is. I'm going to go see an MD.
Well, some people are leery about the holistic aspect, and they don't realize that the DOs have as much medical school as they do. They just view it the holistic piece of it.
That's great. Yeah, I think that's a really good discussion. A few thoughts that I had as you all were sharing, especially at these questions at the very end. A few things that stood out to me is, and I think you guys touched on it a little bit, is, you know, DOs typically will have lower admittance requirements. The GPA, the MCAT might be a little bit lower than MD. Along the same role of that is they can also be quite a bit more money as well. And I think a big part of that is because many of the DO schools are private institutions. And so when you're a private institution, you're able to charge quite a bit more money for it too. And one thing that's really stood out to me is many people don't realize or even recognize what their doctor is. And I think we've gotten to a point where, for the most part, the MD and DOs are on the same level as far as the quality of practice. And I think it more goes to their personality or somewhat of their training in the osteopathic medicine that differentiates them a little bit more than others. But as far as the quality of work, I've always said that you'd be surprised at who has the MD or DO and at the end of their name, but at the same time, I don't think that matters either too. But having said that, as kind of what you were talking about as well, is one of the reasons why within the specialty programs, the higher ups, whatever else you might think of it for the medical doctors, why a lot more of them are actually MDs as opposed to DOs is because, for the most part, it's all about the residency that you get approved and you get placed into. And at this point right now, MD schools get preference over most of the DO schools. And so you might have, you know, 2 separate people. One went to DO school, may even be AT Still University, and another doctor went to the MD school, and they have very similar GPAs, very similar outcomes. But because of that MD school that they went to, they would have more of a choice of what residency they want to go into or what specialization they choose to do. And therefore, you know, that allows them a lot of times more income or more of the choice that they wanted to do to begin with as a result of it. And I think that's why you might see more DOs within a family practice setting or pediatricians, because there's always that strong need for it too. Mm-hmm. And also, like you were saying, is I think the DOs for certain lifestyle, it lends themselves to want to be in those family practice settings where they can work more of a normal setting job as opposed to, say, orthopedic surgery where you're on call all the time, where you always have to be at the hospital, whatever else too. So I really appreciate the time that you've put in to this presentation. You 3 did a great job. Would you like to add anything before I let you all go?
No, thank you, Jennifer.
No, thank you.
I'm good.
All right. Well, enjoy your Thursday evening. Thank you for hanging out with me for a little bit.
Thanks, Brother Gage.
Thank you.
Okay. Have a great evening. We'll talk to you later.
You
All
too.
right. Bye-bye.
Bye.